Hello, good evening, viewers, and welcome to your favorite health show, Ask Dr. Saw. We're coming to you from TBN Studios right here in Queenstown, and Dr. Saw is all the way out in England. Dr. Saw, good evening, and welcome to the show.
Good evening, Akash, and thanks again.
How have you been keeping?
Yeah, I'm busy as usual. It's a bit cold here, but I see the weather has taken a turn, got a little bit colder. But I'm managing all right. Sometimes you need a little, cold
Indeed,
to
indeed.
rejuvenate
Yes, yes, yes.
with all
Great.
the heat that is going around in the
Yeah,
rest of the world.
yeah, yeah. Well, the rainy seasons have kind of start
All
here.
right.
In and out rain. So a lot of people are suffering from flu. As a matter of fact, our boy Robbie got the flu again, and it's because of the weather pattern, and so a lot of people are getting the flu. So I guess the pharmacies and hospitals here are a little busy too.
No, indeed, here as well, there is always the flu season during the winter. Coming up to the winter months, we normally give flu vaccine, and I saw Guyana, we have started that as well, the flu shots.
Yes,
Yeah, so we have that routinely here as well. But yeah, you know, you still have high prevalence during the winter here, and I suppose Guyana has got the same.
indeed. Dr. Saul, last week we were talking about anemia. I have a few questions in the next segment about anemia, but today we're going to be talking about tonight. Actually, we're talking about heavy menstrual bleeding. So, viewers, thank you again for joining us, and I want to encourage you to continue to send in your questions. Send in your questions about what we're discussing tonight, or any other medical condition, ailment, or topic that you would like to know more about. And myself and Dr. Saw are going to go through those questions next week. So today we are dealing with heavy menstrual bleeding. Now, Doc, I know I've been in a number of workplaces where a coworker may not come to work that day because she said she called in and said, "Man, look, this is so bad," and I feel for women who go through that. Not that I can say what I know what the pain is, but when you see people going through excruciating pain, that they are going to probably experience in another month again. That's sad. So here's what I want to start by asking you, Dr. Saul. What is normal periods?
Yeah, no, interesting question. I thought that it would be nice for us to carry on from anemia being a topic last week, and heavy menstrual bleed is a cause of anemia, and it would be appropriate for that to follow on because I have lots of family and friends messaging saying, "Hey, maybe you should address that as a topic," and I felt that it affects large number of women, and I think it is appropriate for us to touch on that and shed some light and see how we can navigate diagnosis and management of heavy period. So your question is, what is normal period? Now, there are two aspects to that. It is difficult. So we have what we call a subjective way of saying heavy period, and we have an objective way. Now, the subjective way is what you feel is heavy. So lots of time it's difficult to quantify that because how do we measure the amount of blood that is coming out?
That's right.
Most women have got pads to absorb the blood. So
Yes.
sometimes it is difficult to quantify that. So we would say that subjectively, women would say, all right, I'm having lots of clots, I'm flooding. The normal pads or tampons that they're using is not adequate.
Right.
And they may have pains associated with it. They may have dizziness and all of that associated with it. So subjectively, they can say that is heavy period, and now they have encompassed that in the definition of heavy menstrual bleed, where the medical community have accepted that it is the perception of the patient that is acceptable. So whereby the heavy period is affecting the physical, mental, social state of that patient. So we would say that is heavy. But you asked the question, what is normal period? So, I mean, by saying that objective and subjective way, I'll give you the objective evidence now, or
Yes.
the objective way of assessing that. But it's just to say that there isn't really um, one that fits all, you know, and that is why we have a subjective way of saying it. Right? It's heavy. It's heavy. Now, however, a normal period, we consider normal period if you have a regular cycle. So we have a cycle can range between 21 to 35 days. As you know, a cycle is every month, and I'll explain that a little bit. So you have a cycle between 31 to 35 days. We can consider that as within the normal limits. Your period would last for about 7 days. That is considered a normal limit. And you would have a blood loss of less than 80 mil per cycle. Right? So that is considered a norm. So if your period is come in more often than every 21 days, that is considered heavy. If the flow, so we talk about frequency, we talk about quantity. So if you're bleeding more than 80 mils per cycle, that is considered heavy. If you're having your period more often than 21 days, that frequency, we consider that heavy. And of course, all the other psychological and physical and social aspect that is involved with it. So yeah, and it is a very common thing. It is estimated about just over close to a quarter of the population of women age over 30 would probably have some degree of heavy periods. And inevitably, most women, as a matter of fact, at some point or the other, they may have heavy period during their menstrual life. So at any point, and that's the thing, because I will get to the causes and then I'll tell you, because it varies so much that you can have no period sometimes and you can have heavy periods sometimes, and every woman would tell you that at some point in their lifetime of their cycle, they have some variation.
Right, right. Absolutely.
Yeah.
But in going through the processes, doc, also I would like, why is it that some periods are so painful for
Right.
women?
Yeah, no, indeed. Well, that is coming to the cause. So
Yes.
when you have periods, there's a complex mechanism. So let me just tell you a little bit of how the period works.
Absolutely.
And when we understand that, then we can understand why some are more painful than others. So normally your body there are some hormones produced in the brain, and they send a signal to the ovaries. And the ovaries in your pelvis, so you have 2 ovaries and then your womb, right? That's how it is. Your ovaries produce another set of hormone, but the regulated hormone is in the brain, send a signal to the ovaries. The ovaries then produce hormones that cause thickening of the lining of the womb. And in so doing, so that is called in the beginning of the womb now has got a layer, right? It's got a lining, so that's a layer. It's got a certain level of thickness. And every month, because of these hormone variation, the lining builds up in preparation for an egg, for
Right.
a fertilized egg.
Yes.
And that's the mechanism of how you get pregnant, right? So your body produces these hormones that stimulate the lining of the womb, and the womb start to increase in size. So the thickness start to increase. We call that the proliferative phase. So the size, it start to get thickened, and if you have a fertilized egg, it comes in there and it gets implanted. And if that doesn't happen,
Right.
you shed that lining. So it's a cycle of the hormone.
Right.
It's how the hormone is released, then you have a surge, then you have a drop in the concentration, and then it sheds the lining of the womb because there's no egg.
Right.
If there's an egg that is fertilized and gets implanted, so you're getting a baby now, you're pregnant, you don't shed that womb.
Right.
So you don't shed that lining. But if there's no egg, and every month you're producing that egg, a new egg is released every month,
Yeah.
and so that is what caused the period. So the period is caused by hormonal influence that create preparation of the lining of the womb for a fertilized egg. And if that doesn't happen, you just shed it and it gets expressed as period. Now, why do we get, so there's a complex mechanism in that. And the complex mechanism is the hormonal drive. So there got to be hormonal factors and they have to be uterine because the hormone exerts its effect on the womb. Mm-hmm. So usually the pain is driven by the uterine factor. So the blood flow in the womb, the muscle contraction. So the muscles of the womb will contract to regulate, to press the knees on the blood flow. So if you're bleeding, you don't want to bleed excessively. So there is some control mechanism in the body, has to do with the chemical that controls bleeding. So we call it the coagulation chemical, the clotting chemicals. They can control the amount of blood you pass. And then it has to create a clotting system so you don't bleed forever. Mm-hmm. And when those systems deranged, that's how you have the pain and the amount of blood loss. And of course, there are also sensitivity of the pain receptors because there are lots of hormonal factors at play. So there may be upregulation of the pain receptors and it gives rise to all that pain. However, there are some specific causes that you will get more pain than others. And that is when we look at why do we have heavy period and what causes it, depending on the cause, can determine the extent of pain. So, coming to the cause, if you have something like fibroids,
right,
you can have a lot more pain. So let us just talk a little bit about the causes, and then you would understand why you get more pain with it.
Yes.
So yeah, okay. So as I say, I can divide it for simplicity. We can divide up this whole heavy period into two sections. We can say you have got heavy period because there's a structural problem in the uterus. So we're looking here at the uterus and we're looking at chemical flowing that control the bleed, right?
Yes.
So we can say that you have a structural problem in the uterus. That is, there is something in there that is causing you to bleed. And what are the things that can be in the uterus itself or around the uterus? So the uterus has got different lining. It's made up of a outside covering, it's got a muscle sheet, and it's got an internal part, and that's called the endometrium, and that's the part that you build up and you shed every month, right? So that is called the endometrium, the inner part of the womb. And the middle part is called is a muscular part, myometrium, and the outer part is called the perimetrium, or the outer lining, right? So the thing is, if there is, okay, so let's start with fibroid as a cause. So I'm looking now at structural cause. Mm-hmm. So there's something going on in that uterus that makes it, doesn't contract well, the blood flow is not well, the cavity is distorted. Imagine the womb is like an upside down ball.
Right, right.
That's the shape. Or like a pear. Mm-hmm. Okay? And so the cavity and its line, let's say you make that into a hollow ball.
Yes.
So the lining meant to be smooth and clear and not distorted. But if you have something like a fibroid in there, what is a fibroid? A fibroid is a benign tumor. So a tumor is a swelling, like a lump, in the uterus itself. So it could be either way. It could be in the inner lining, it could be in the middle, in the muscle, or it could be in the outside, the wall that covers it. So we describe it as intramural and subserosal and submucosal in terms of how we describe fibroid. So if you have a fibroid there, the fibroid is a tumor, a mass. It's not cancerous. So when you're bleeding, that can get into the way. That has got its own blood, that's got blood supply to it as well. That can distort the cavity, the lining, and that can give rise to pain because it is big, it is all enlarged. So women who have got big fibroids, they can have more pain during their period. another cause. The lining of the womb, I said to you, has got an inner lining called the endometrium.
Right.
And that should be the inner lining. Sometimes that inner part that is rich in blood supply and has got cells get into the middle part. The middle part meant to have muscle, is a strong muscular layer. When those inner part with blood vessel and cells, when they get embedded into the middle part, it's a condition called adenomyosis. So think about it. You've got some abnormal architecture,
Right,
meaning
right.
into that middle part. So when the womb contracts, you get more pain. You bleed more because that part now, besides only the inner part is full of blood supply, you have that middle part that's got blood supply. And the uterus get bigger, it get bulky, you get more bleeding, you get more pains. So that is one. So we get fibroids, we get adenomyosis, that is called. And then you have another condition called endometriosis. So these are all structural, so we're still on structural causes. So physical causes, so you find something wrong with the uterus. And the endometrium is that inner lining again that you meant to shed. That can get deposited in other organs of the body. That's supposed to be only in the lining of the womb,
Right.
in that inner part. And that's the part you're shedding. If that gets moved or it gets, it is on the ovary, that is called endometriosis. It can get on the bowel. It can get on the covering of the tummy, the peritoneum. So when you get that gives rise to pain and severe. You get heavier bleeding, more pains. So that's another cause. And then importantly also, the lining of the womb is supposed to be of a certain thickness. And if that lining expands and it's thicker than normal, you can have excessive bleeding and pains. So that is called endometrial hyperplasia. Now this is a very important condition because patients who have thickening of the lining, they can have a higher risk of cancer of the womb. Because that inner lining got to be of a certain size.
Right,
and if it
right.
gets thicker and thicker and it gets abnormal growth, you can have cancer in that lining of the womb. And that is called endometrial cancer. So importantly, now all of these conditions that I've described just now, they all can cause heavier bleeding associated with pain. Now, there are other factors. Well, you can say, right, you have period pain, we call it dysmenorrhea. They can also cause irregular bleeding. So the bleeding is not cyclical. It's not like once every month. You can have 2 times, 3 times a month. You can have also pain on intercourse. Dyspareunia, we call that. Because you get deep pelvic pain. Because you have lining of the womb outside of the womb. You've got thicker womb. The womb wall is thicker. So patients, a lot of women will complain of deep pelvic pain. And especially during intercourse, it's more painful than other times. So these are the structural or physical causes of causing heavier period. Now let us look at, so that is one, and now we have what we call the non-structural cause.
Right.
Now these are all hormonal and chemical, majority of causes, hormonal chemical imbalance. So I said to you that your brain produces some hormone, it gets acted on the ovaries, and the ovaries send the signal to the uterus to form the lining. If there is an imbalance between those hormones, how it is balanced out, it has a nice balanced way of doing that in a nice cycle. And if you have a disturbance of that, you can have irregular and heavy period. So when a patient comes to you and say, Doc, I'm having heavy period or irregular period, the first thing I want to do is to ensure there is nothing physical. So I'll look for physical things, and then I will look for those abnormality in the hormones. And then you can have some other general medical condition. Like if you have a bleeding disorder, when you cut yourself, you're supposed to have your blood takes on time and it clots the cell.
That's right, yeah.
So exactly. So in some people, they have clotting disorder. and they bleed heavier.
Okay.
You can see that something you shave and you bleed continuously.
Yeah.
If you're inserting blood thinners, and even like aspirin, and there are certain special type of blood thinners. If there are some patients who are prone to blood clots or they have an irregular heart rate, we give them blood thinners every day, which are stronger than aspirin. And in those patients, they can have heavier bleeding as well. Or if you're born with some genetic or have a blood disorder, your liver produces clotting factors. So if you have a liver disease, you can have a clotting disorder. And there are general conditions like also thyroid problem. If your thyroid is too high, too low, all of this whole mechanism of hormonal control, they can all cause bleeding disorder. So that's your general take on the causes and why sometimes, depending on the cause, you can have more symptoms than others.
But doc, besides well, no, there are some serious issues here that I believe that can be, well, I believe they can be fatal. But besides having heavy periods and heavy menstrual bleeding, what else can point to these problems that there is a, so you get to know that there is a problem.
Yeah, so I just, right, indeed. So heavy period is heavy period. You come and report that. But also, I just explained, you can have pain on intercourse. So if a woman comes to you and say, Doc, I'm getting normal period, but I'm having severe pain on intercourse, I may also want to check. It could be also infection in the pelvic infection, but endometriosis is a cause where the lining of the womb gets into other parts of the pelvis. So you can get that, and of course, painful period. But more so also, if you're bleeding heavily, sometimes you don't pay much attention to that, and you consider that normal, but you can have signs of anemia. And what are the signs? You feel tired, you're fatigued, you feel dizzy. Some people black out. I've got patients who, they have blackouts often, and when you check their blood count, they're so severely anemic, and it is all because of heavy period. So you can have general weakness as a result of anemia. So you have your anemia symptom, and then you have the symptom due to the cause of your condition. Also, if you have a bleeding disorder, you can have bruises in your body. So patients wake up and they have, in Guyana we say old hike sockets.
Yeah, that's right. Yeah.
So that's a bruise.
Okay.
That sometimes that can be a sign that there is a bleeding problem in your body, that your blood is too thin. So these are things we do not just trivially. Yes, a one-off I wouldn't pay much attention to, but if you're having this regularly, you have to pay some attention to that.
All right, doc.
Sorry.
Yeah, time is going for us, so I'm trying to get into. But I met somebody recently, and the person was in severe pain. I said, "What's going on with you?" And he said, "Well, they have something called polycystic ovary syndrome, and
Correct.
she gets her periods maybe like once a year."
Correct.
And
so peace, yes, correct. Go ahead.
Yeah. So maybe this is another subject or a topic we may have to discuss because right. So, but so if in a very short way, if possible, the shortest way possible, what is that?
Right. So that's called polycystic ovary. So there, I want to distinguish two conditions. So one is called polycystic ovary, and one is called polycystic ovarian syndrome. So what is that? And people say PCOS.
Right.
So I said to you that our body has a regular way of producing these hormones, and you have a regular cycle. In polycystic ovaries, when you look at the ovaries, so the ovaries have got immature eggs, right? And every month these eggs mature, and you release an egg, and that egg you get, if there's a sperm there, it reaches the egg, it fertilizes, you have a baby. But in polycystic ovaries, you have all these immature follicles that sometimes they don't burst and bring out the egg.
Okay.
So you have these follicles, they get arrested. They don't reach full maturity to form fully. So you have follicles, immature follicles, or you have follicles that grow halfway and they're there. So they form cysts into the ovary. So we call a polycystic ovary. Now, when you have the whole condition now, and usually that is caused, we don't know the exact cause. The whole genesis of that is so elusive that we don't know exactly, but there are lots of theories. So the theories is like a hormonal imbalance.
Right.
Right?
Mm-hmm.
So this hormonal imbalance, it creates other hormone to produce excessively and some to produce less.
Okay.
So what tends to happen, our body also, women also produce some male hormone, and what tends to happen, testosterone, in the polycystic ovary, these patients have high testosterone. So when we talk about polycystic ovary, you can scan an ovary and you see some cysts, and you say this looks like polycystic ovary. But then you have the polycystic ovary syndrome, which is like the full-blown disease.
Wow.
So you have a spectrum of it, where at one end you have polycystic ovaries, and as it gets worse and worse, you have the whole ovarian syndrome, where the chemical imbalance is there. You have high level of testosterone. Your periods are all irregular. You also have facial hair. You have acne. You're overweight. So we find this happening in overweight patients more, and you can have insulin resistance. So these patients can be pre-diabetic or their sugar a little bit high, borderline diabetes. Now that is a condition called PCOS. And we don't know the exact cause, but there's a hormonal imbalance cause where you have high level of male testosterone and your whole hormone is not in sync.
Okay.
Now, we've got just about...
I think about five minutes more. Yeah, 5 minutes more.
Right.
So here's what I want to ask, Doc.
So,
Sorry. Because of time, I want to get this in so that in your flow, I don't have to stop you again. What tests can be done, and at what stage? Because I know somebody. Years ago, I met her, and she was having these issues. I said with workplace issues, and then she had to perform a hysterectomy. At what stage is that required?
All right. So we come to that quickly because we got 5 minutes. So I want to talk. So what I will do, a patient comes into me with heavy bleeding. I say, first of all, I want to do 2 sets of tests. I want to check a scan to see if there's a structural problem. So the test I would send for is an ultrasound. It's non-invasive. It's okay. We do a scan. We check if you have fibroids and thickening of the lining of the womb and all of that. So that's your ultrasound. You can also have MRI scan as well, but ultrasound would be your first non-invasive. It's a cheap test and it's good. The second test I would want to do, I would want to run some blood tests. And the blood tests you would want to run, you want to check if the patient is anemic. You want to check the iron level. I want to check their clotting to see if their blood is clotting in order. And I would want to do some hormonal, include thyroid and all these hormones to see if there is an imbalance or excessive or shortage of some hormone. That's your test. And in other invasive tests, we can then put a camera into the uterus itself and have a look around. So that is called hysteroscopy, right? So that's your test for that person. Now, coming to when do we give a hysterectomy? So let's run through treatment quickly.
Yes.
So we know that, so if there is a cause of your problem, so we find you have fibroids or something physical, thickening of the lining, we can treat that. So you can remove the fibroid, you can do all of that. Now, but coming to the management, both for if there's something physical, because these treatment, there's something called dysfunctional uterine bleeding in the past, or abnormal uterine bleeding, where there's no cause. There's just some hormonal imbalance. So there's nothing physical, there's hormonal imbalance. So the first thing we could do, we could treat it by what we call non-hormonal means. So we are now worrying about the hormonal imbalance. We're just saying, these are patients come and say, Doc, I don't want hormones, I don't want anything invasive, give me the mildest treatment. So there are 2 drugs we give. One is called tranexamic acid, and that deals with the clotting of the blood. And then another one is called mefenamic acid. It's a family of ibuprofen family. So it also decreases bleeding, and it is work as a painkiller as well. So you combine these 2 drugs. They're not hormones. They just work on pain relief and blood clotting cascade, right? So that's your non-hormonal. And then you have the hormonal treatment. So if I said to the patient now, all right, your periods are heavy, it's irregular, let us try something more specific. Because you have a hormonal imbalance, let me start you on the contraceptive pill. Straight contraceptive pill, because it has a balance of the 2 hormones. I'll give you that to balance back your hormone. You use it, the pill is used like 3 weeks. You then stop for 1 week, you get a period, you start back every 3 weeks, 1 week off, 3 weeks on, 1 week off. and you get a regular period, it decreases the heaviness, and it gives you a regular period. So that's your normal contraceptive. And then you have something called the contraceptive is made, usually the combined pill has got 2 drugs. There is also something called a mini pill, or progesterone only contraception, or the progesterone only pill. We can give the progesterone only, and it comes in pill form, it comes in injection form, and it comes in implant form. So we can give you that, and sometimes you stop the period altogether. The oral form, the tablet form that you have for contraception can cause irregular period as well. So we don't use that very often, but we can use the injection form of it, or a higher dose of the progesterone, not the contraceptive type, but one of that progesterone only hormone, and that can stop your period. So that's 2. The third thing we can give, I told you that there are some hormones in the brain that control the hormone in the ovaries. And these come as injections. You can have injections that stop the brain hormone from releasing, so it doesn't stimulate the ovaries. So that's another. So these are all injections, tablets, and all of that. And also we can put a coil. There is a coil called a Mirena coil. You put in the uterus, and it releases a hormone, progesterone, and it decreases the amount of bleed.
Okay.
So these are all your medical management. Now we go quickly onto surgery. How many minutes do we have?
Well, we're just about time, but I'll give you. We have 2 more minutes.
Quickly, on the hysterectomy part. So now we come to the uterus itself. How do we do? So let's say we try all these medical management and it doesn't work. Then we can do some surgical management. What are the surgeries can be done? We can do something called endometrial ablation. I told you that the lining of the womb is thickened.
Right.
So we can use a probe, put it in there, and burn the lining of the womb. And there are various ways of doing it. They have hot wire probe, they have laser probe, they have lots of things. You can have some they put a balloon in it with hot water as well, saline, and it can burn the lining of the womb. So that is called endometrial ablation. You just burn the lining, so there's no blood bleeding after that. So most patients, they wouldn't have a period after that, right?
Is it, Doc, let me just ask this quickly. Is it the same method of how a cauterization happens? Like when you...
Of course, that's like a method, right? The hot wire, cauterized, so similar. But now they have lots of procedures. They have loads of... That has evolved into hot wire, into laser, into different means, right? But the idea, we've got the idea. The second thing you can do, you can block the blood flow to the uterus. So the uterine artery carries blood to the uterus, and this is used more in fibroids. If there's a fibroid, we inject something in the artery and block it. And that causes the blood supply to the fibroid to cut off, and the fibroid shrinks and fall off.
Oh.
So that's called uterine artery embolization. So you put a little catheter through the groin in the femoral artery, and you thread it up under guidance, and you inject something to block the vessel.
Okay.
Now that is called embolization. And then the last resort, if nothing works and a woman has got babies and everything already, we can say, let's do a hysterectomy. And that is, your last resort, hysterectomy. Now, just say in the UK, we do about 400,000 hysterectomy a year for heavy bleeding. And of course, the world, even America, will be a lot more.
And just for clarity, Doc, sorry to interject again, but just for clarity, the hysterectomy is the removal of the womb.
The womb is called the uterus.
Right, yes.
Right? The uterus is called the womb, yes.
Yeah.
So hysterectomy is removal of that. So you can do, they have different types of hysterectomy where you leave the bottom part, which is called the cervix, or you remove everything, and you can remove everything including ovaries, or you can leave the ovaries as well, because the ovaries still produce hormones. Because if you remove everything, then you go into menopause. If you don't remove and you leave the ovaries, your ovaries will still produce hormones, so you are not into menopause. It's just you wouldn't have a period. But when you remove womb and ovaries, you go into menopause. Right? So that's a good point for patients to understand as well. So we can just take out the womb, leave the ovaries, you will still be normal. It's just you wouldn't have a period and there is no womb there. All right. I think we have covered most on this aspect? How the timing looking?
I think we're up on time now. Yeah, we're up on time now. All
All
right.
right.
So Doc, we're gonna take a break here. This topic would we can go on it, but I hope that some of the you our viewers, you're asking questions to Doc. We are out of time for this segment where we do the informative segment and educational segment, but we are going to be back in just a few with your questions and the answers to your questions from last week. So see you in a few. Hello, viewers. Welcome back. We're here again. That was an amazing discussion. But Dr. Saw, my respect for women has just grown about tenfold because when there are so many things that our women folks go through, and I want to make an appeal here also that as men we should be supportive of them when they're having these issues because psychologically I can imagine as a man if if I got something slightly that bothers me, it takes a toll on me. So I really do. I don't want to say empathize, but I understand. Sometimes we need to understand what women are going through, and thank you so much for your explanation on what is really happening there. Viewers, as you know, this segment is where we're going to be taking your questions from last week, and Dr. Saw is going to be answering those questions. So last week we were dealing with anemia, and some of the questions that I have here, Doc, is from that show.
Sure.
The first one
Yeah,
is,
yeah.
Doc, is anorexia directly related to anemia?
The answer would be yes. It is related, and I'll explain how. So, what is anorexia? Anorexia is loss of appetite. And you can lose your appetite for various reasons. I mean, if you are ill, you have the flu, you lose your appetite. So first, I will talk briefly on anorexia, and I'll show you the link between that, right? So anorexia means loss of appetite, and that can be for various reasons. So patients with general ill health, I mean their illness, any illness, be it flu, be it something more chronic, malaria, TB, whatever the infection is. So you can have an infection and you lose your appetite and you become anemic. You can have cancer and you become anorexic. You don't have taste, you don't have the energy to eat and to eat as much as, and you become anemic. And of course, there is a special condition called anorexia nervosa. So I just want to distinguish the two conditions. You have anorexia for various causes, that just loss of appetite, and you have anorexia nervosa, where it's more of a psychological issue and a mental health issue in classifying it in that category or that group. Where these patients, they have some psychological, and the cause is exactly not known, but it's an imbalance in their chemical, and lots of theories are being postulated, social, environmental, genetic, and neurochemical factors that give rise to anorexia nervosa. Now that's a special condition, psychological condition that makes you're preoccupied or more obsessed about your weight, and you want to have a certain weight. You cannot distinguish really what is the normal weight for your age group. And we find this can happen more in the younger age group of patients. It will be difficult for us to diagnose anorexia nervosa, in older patients. We tend to get it more in the younger 16, 17, teenagers age group. And of course, it can be a little bit older than that. But that's, as I say, it's a multifactorial cause for that. But how does it relate directly to anemia? We said that anemia means you've got less hemoglobin or less red blood cell, because the red blood cell is made up of hemoglobin. So either you have lower levels of that, and we talk about anemia being, you need production of the red blood cell. You could, so if you have less production, you'll be anemic. or if the blood cell is being destroyed, or if you're losing it. Right?
Okay.
So that's it. Three, how I categorize it.
Right, right.
So when you categorize it like that, so in anorexia, you don't eat enough of the compound, the ingredients to give you the red blood cell. So the formation is deficient. So you don't have enough iron. You don't have enough vitamin B12, folic acid, because you are not eating a proper diet that contains all of these nutrients. So you produce less red blood cell. And inherently also, as I say, loss of appetite can be for various medical conditions that can also suppress the bone marrow itself. So they're twofold. One, you can have it because, and that's where the anorexia comes in. Depending on the cause of anorexia, you're not taking enough of the nutrients. And secondly, even if you have enough of the nutrients, the body ability to produce the blood is weakened and lessened, and you have anemia. So that's your direct correlation.
Oh wow. So because and then you're right. I see some lots of time anorexia is the related or being how should I put this? A lot of times we think that anorexia is only people who have this psychological issue that they need to be
No. Patients with cancer, they're anorexic.
Right.
You see people losing lots of weight because they've got cancer. You can have, Crohn's, ulcerative colitis, stomach ulcers. There's so many things can make you not. But the one you're referring to, the psychological one, is more defined as anorexia nervosa.
Right, exactly, yeah. Right. Next question is, Doc, is it safe to have too much iron in the body?
Not safe, and that's why we don't give you iron as a injection form all the time, or we don't say, if we find somebody with high iron, we normally go to investigate. There's a condition called hemochromatosis, where your body don't metabolize iron well, and it gives rise to high iron. Now, here's the deal. Iron in the body has got a metabolic pathway. It is processed in the body in different ways, right? And our body has a safety mechanism where it absorbs. We get iron from the food, the body absorbs the iron, and it takes it to make red blood cell and hemoglobin, we call that. But our body sometimes absorbs what is needed. So if your iron level is good and you're taking iron, sometimes you don't absorb the whole lot. You only absorb 10% or 20%, depending on what the body needs, and you excrete the rest. So that's your protective mechanism. But if somebody has got high excessively taking lots of excessive iron, one, they can have side effects from the iron, the stomach issues. So you have, and then you have gastrointestinal constipation issues. Your stool is dark, it's black, it gives slightly more sticky, and those type of problems with excessive iron. But when your body has a way of metabolizing or regulating your iron, but if we find high levels of iron in the body, it can build up into the organs. And if you have iron build up into your liver, for instance, your liver will malfunction. If it builds up in the kidney, it will malfunction. So we do not encourage necessarily iron as an iron overload for you to keep taking lots of iron. But most of the time you don't get it absorbed, so it's not an issue. And young girls or people with periods, they need iron on a constant basis because they're losing the iron. Generally, I would not give iron to unless they have a deficient iron deficiency that is not eating enough iron-rich food, or if they're bleeding. And then we look for bleeding, as I spoke earlier, we look for occult bleeding. So when a man is anemic, always look, we want to make sure they don't have hidden blood as a result of cancer somewhere, and that is in the gastrointestinal tract, the urinary system, these things. And women likewise, if they're not period, and we call that postmenopausal women who are now having period, if they're low in iron, again, we look for the similar causes that you would look for in men in terms of hidden loss.
Thank you. Viewers, just as a reminder to continue to send in your questions, and next week we are going to be dealing with those questions. Next question here, Doc, is, can fibroids lead to anemia? Well,
Yes. So again,
Yeah.
recapping that, so we just
Right.
talked about fibroids
Indeed.
and heavy period. So when we look at anemia again, I just want, I like patients to get the gist of it very clear. We have production issue where you're not producing enough. You have where you're not having the ingredients, so you're not eating enough, or you're losing the blood. So in fibroid, obviously, the cause of your anemia now is going to be blood loss.
Mm-hmm.
Because in fibroid you get heavy bleeding. We just spoken about fibroid as a cause of heavy bleeding, and of course that would give rise to blood loss, and you lose the iron, and you have low iron, you're anemic, and that is as a result of fibroid. But just because time was running out
Right. Indeed.
in the
Yeah.
first segment, I just want to spend a couple of minutes and talk about fibroid on its own. Maybe that may be a topic at some point on its own, because
Indeed. Yes.
fibroid is so common.
Yeah.
And, they say about half of the women have got fibroid if we scan them all, but it's small, and maybe we don't know to treat it. And as you get older and into menopause, your fibroid would shrink. So,
Okay.
because one of the treatment of fibroid is to induce menopause. I said that the cause of fibroid we don't know is a fact is multifactorial. So you have some hormones of the uterus, and you have some inflammatory processes going on, and these hormonal factors, they go and they stimulate the uterus, and you have these tumor formation in fibroid, right? So that's how it is formed. And of course, certain risk factors are involved. There are certain groups of patients that are more prone to fibroids. Now, when we're managing the fibroid, if we know that the hormonal influence is causing the fibroid more, what we want to do, we want to block the hormone.
Mm-hmm.
So if you're having excessive stimulation from the hormone, we can block it. And how do we block it? We can block it by the traditional means of giving you a more controlled regulation of hormone. So you give the pills and the contraceptive pill and the progesterone only pill, maybe, to just block not having period. Or we induce menopause. We know that menopause shrinks the fibroid. I just said that.
Mm-hmm.
So we can give you an early menopause.
Okay.
So what we do, we give you drugs to give you an early menopause. But what is the danger of that? If I give you an early menopause, we know that in patients, postmenopausal women are at higher risk of ischemic heart disease and bone, it weakens the bone. So that's why you get frail and your bones get weaker as you get older in postmenopausal women, because the estrogen protects the bone. So if I give you menopause earlier than normal, your bones can get weaker. So one of the things we do, we block the hormone, create menopause, and then we give you back the hormone in the form of HRT type of hormone.
Okay.
So that's it's a way that we can use. And now, not recently, but traditionally, you used to have injections to induce menopause. Now there's some tablet form of it. So there are new class of drug in the past 4 or 5 years get licensed by the FDA in America and the UK, MRA. They have the tablet forms of these hormones that can block the hormone, and they combine it with replace back the hormone. So they give you in one tablet,
Okay.
where part of the tablet blocks induced menopause, and the part gives you a control way. And now the evidence, there are some studies that have shown that if you maintain the amount of the hormone at a certain window, at a certain level, you get the fibroid shrinks, or it gets less, it grows less. So you can have control. So when I block it totally, I can give you just the amount that is needed to protect your bone.
Right. Right. Interesting.
And so that's a new class of drug. They
Yeah.
call it GnRH antagonist,
Okay.
where it blocks the release of the pituitary hormone.
Wonderful. Um, Next question, Doc. What is the difference between ferritin and hemoglobin?
Good question, and just let me explain that clearly. So I said the definition of anemia is low level of hemoglobin or red blood cells. So 95% of the dry weight of red blood cell is made up of hemoglobin. And hemoglobin, the heme in it is iron, and globin is protein. And that's why it's called hemoglobin. But remember, the red blood cell, I said 95% of the dry weight of that is made up of hemoglobin. And the iron form of the hemoglobin, it's got iron in it. So hemoglobin is made up of iron and protein.
Right.
So the difference with iron, the iron is in the hemoglobin, and the iron is what, that hemoglobin is what the oxygen is attached to that move around the body. So when you breathe in oxygen in your body, it gets attached to the red blood cell, but it's attached to the hemoglobin itself, and it gets transported to the rest of the body. So it moves through. So the oxygen attached to the red blood cell, it goes through the blood vessel, and it flows to all part of the body where there is blood.
Right.
Now, the ferritin is iron. It is different from hemoglobin. It's just a component of hemoglobin.
Okay.
So ferritin is used for hemoglobin. And when you look at anemia, you're not measuring the ferritin level, you're measuring the hemoglobin level. So if your hemoglobin is normal, you can have low. Ferritin is an ingredient for hemoglobin, put it that way. So your ingredient may be low, but you're still making enough for now. It is only if your ingredient gets very, very low, then it becomes a problem. Then it starts affecting the production of hemoglobin. It's like your car tank full of gas. You still can move from point A to point B if the car is full, or if the car is half tank, you'll still move from point A to point B.
Absolutely.
But you have low level. Your gas tank is low level.
Yes,
So
yes,
that's
yes.
your ferritin. So your ferritin can be low level, but it's still enough to do the job, to produce red blood hemoglobin. So that's a simple way of understanding it.
Great way of explaining it too. I heard. Next question is: I heard molasses helps with iron deficiency. Is it true?
I need to go through. I mean, what are the things in molasses? But we know molasses is part of that sugarcane
Right, it's a byproduct.
sugar. Yeah, some one of the product of that. I mean, I've seen and I've tasted molasses before.
Yeah.
Growing up in the country. But molasses, the reason is it will help it is rich in iron. So that's the reason. Molasses has got a high level of iron.
Right.
So the iron in it, but of course it's got other things in it. It's got sugar, it's got carbohydrates, it's got, other ingredients. I mean, molasses is rich in minerals generally, iron, calcium, magnesium. So yeah, it may be good, but I don't know the downside. I never researched molasses on its own to know all the health benefits of it. So maybe I'll have to look at that at some point.
Yeah, because.
But I know the iron content is high, and that may be one of the things. But again, if your iron is low, I would prefer to take iron because I don't know what else is in there. I'll take iron supplements. But of course, if you use some of that, I don't think it will do you any harm.
Okay. At the end of the show, I'm going to ask you about another use of molasses that I don't know if you've ever heard of, but I'll ask you about it just now. Next question is: how often should I monitor my blood levels? I like this question.
Yeah, that's an interesting question, to be honest, and I get it all the time. Patients come to me and say, "Doc, can I have a blood test?" Now, in the UK, as you know, healthcare is free. Right? Like Guyana, healthcare is free, but I mean, here is accessible in the sense that patients would come, they register with the doctor, and they can book an appointment just like that anytime.
Yeah.
And they come, and lots of patients come specially to request blood tests. I want to check if I'm anemic. I want a full blood count. I want to check my kidney. Now, if we were to just give in to all the blood tests and request, it would not be cost effective for the health service. Think about it. So sometimes we say to patients, what are your concerns? Because my job also is to educate them, to understand their concerns, and to really put their mind at ease. It's not for me to blanketly say I can't do it because it costs money. It's to say that, okay, why do you want it? Okay, let me explain. It may or may not be needed. So the question is, how often should you have it? In young people who don't have any disease condition, generally we don't need to do regular blood tests. I mean, a one-off blood test whenever you're ill or you don't feel well. If you have symptoms, we would do a blood test to find out if I don't know. So if you're tired, your eyes are yellow, you're pale, and we're looking for something, or you have infection, I can do a blood test to find out what is going on. Is your kidney okay, your liver good, your blood count is good? Now that's different. We're talking about a healthy patient walking into your clinic and say, I want a blood test, and how often they should have it.
Right.
So the frequency of blood tests has to do, first and foremost, I would say, one, are we dealing with a healthy patient?
Mm-hmm.
If it is a healthy patient, if you're young and you're under 40, and you don't have any known medical condition and you've had blood tests in the past 5 years, I may not recommend a blood test for you. I would say, fine, if you have a health risk, I can do a blood test to look at risk profile. What's your cholesterol, what's your sugar, and maybe help you to understand that. Are you drinking excessively? So, yeah, but if you're healthy, maybe I will do it in a couple of years, every couple of years, just for your own well-being, and just to reassure you that you're good, right? But I wouldn't say every year you have to have a blood test. So young patients under 40, they do not come to me and say, they will come, but we don't have a protocol. So every year I have to do a blood test for you.
Right.
It would be a one-off. That is in your young patient, no disease condition, they're fit and healthy, they don't have no worrying conditions. I would not do regular blood tests for them. If you have got disease conditions now, depending on the condition you've got, we'll do regular blood tests. So, if you have things like diabetes, kidney disease, I will do blood tests between 3 to 6 monthly. So, if you have, because I want to see how your sugar is controlled, we want to monitor your kidney, things. So, normally 6 monthly is okay. 3 monthly, I will do it if I find a problem. So, I'm trying to get your control back to normal. Your cholesterol is high, your sugar is high, I have given you a medication, and I say, okay, let us repeat it 3 months minimum. There's no point I give you a cholesterol tablet and or a blood pressure tablet, and I do your tests earlier than that. You know why? I haven't given your body enough time for the medication to work. Mm-hmm. Why am I giving you a cholesterol tablet and say 2 weeks after let's do a blood test? It's not enough time for it to work. Yeah. Likewise, when we monitor sugar, we monitor the average sugar over 3 months. So the minimum time you can retest it is 3 months. Because I'm doing the average over 3 months. So if I start a medication now, I want to see. There are some guidelines whereby if I start a drug like a cholesterol tablet, I may want to monitor your liver 6 weeks after. So now that is different. Or if I start some medication we want to see, like in high blood pressure, if I start the drug from something called ACE inhibitors, I want to recheck your kidney function between 1 to 2 weeks to see if there's a change in your kidney function because I've started a new drug. So those are different indications. So you can have those tests when you do an intervention and you're looking for something specific. But if you're looking for a routine, and I suppose the intention of that question is how often should you have your routine blood tests? So let's go ballpark, I would say. In patients with diabetes, if I'm trying to adjust their medication every 3 months, if they're stable on medication, their sugar is well controlled, I would say 6 monthly. In patients with high blood pressure, if I'm not making any changes and their blood pressure is well controlled and their standard medication, I'll do their blood test yearly, once a year. And for general health well-being,
right?
Let's say you're over 50, and you want to check your cholesterol and you just want health check, once a year is good enough.
Brilliant. Because that was going to follow up with you.
Yeah. So that's the one I would say once a year. I can say fine. I'm happy to check your cholesterol, check your blood sugar, these things. However, if there's a special cause, then we do it earlier than that. I mean, there are times when we find an abnormality in the blood. So if I do a blood test and I find that this patient's white blood cell is high, sometimes I'll say, can you repeat this in 4 weeks? Or the inflammatory markers are high. There's no unless it is so high that I want to keep an eye every week on it, then I'll repeat it in a week or two. But if you're to see the trajectory, to see if it's going down or up, the trend. But if I'm looking to say, right, your inflammatory markers, your white blood cells are slightly high, there's something called ESR, CRP, these are called inflammatory markers, but you are healthy otherwise, I'll say, okay, let me give it at least 4 to 6 weeks to see if your body will recover or this will normalize.
Brilliant.
So you always bear in mind that give the patient some time, depending on what they're looking for that to war, rather than prematurely do a blood test.
Wonderful. All right, last question, Doc. Are there any dietary restrictions I should follow while managing anemia?
I don't think you should follow dietary restriction. You should probably improve on your diet. Not restrict it, but enhance in certain ways. So the enhancement would be food rich in iron, green leafy vegetables. We know is rich. Meat, red meat is rich in iron. But of course, the downside is still looking at cholesterol level. Red meat too much also, it's got other downside to that. So yeah, green leafy vegetable is good. Iron-rich food generally you'd want to enhance your iron intake for anemia. But also, besides iron, remember anemia can be due to vitamin B12. So animal products, B12, and folic acid. That is rich in legumes and nuts and those things, green leafy vegetables. So your iron, your B12, your folic acid, if you have lots of that, it will improve iron, and those things are needed for production of hemoglobin and red blood cell. So I wouldn't be restrictive. But just a point to note here, if I'm taking iron supplement, and I mentioned that the last time, that sometimes we don't want to use things that would decrease the absorption. So if you drink tea, it can decrease the absorption of the iron in the body. And also, and what to enhance the absorption is vitamin C. So using it with orange juice will make your body absorb more.
Wonderful. All right, Doc. Thanks so much. I want to ask you this last thing about molasses. When I was a kid growing up, on the island of Wakenham, I heard that if you wanted to catch monkeys for pets, you leave a little bit of molasses out, and they would go eat the molasses, and they get drunk, and then you go pick them up easily. Have you ever heard of that?
No, never heard of that with relation to monkeys, but I'm just trying to think. I know they use molasses to make rum.
That's
so
right, you're right. It's possibly that they get drunk too, right? Because the little bodies. Yeah. Doc, thank you.
Yeah, you suppose there's some alcohol in that.
Indeed, yeah. Doc, thank you so much for joining us tonight. I know you have a busy schedule, having to deal with clinic and then, get there to do the show. Thank you so much. And I'm sure from the comments I get that the viewers, our beloved viewers, are really appreciating what we're doing here, especially you, Doc, bringing this knowledge out to the public. So from all of us, we want to say thanks to you too.
Thank you as well, Akash. Without you guys, this would not be possible. So thanks to you and your team again, and to the viewers, thanks for listening.
Viewers,
thank you and good night.
Yeah, viewers, thank you so much for joining us tonight. It was a good conversation tonight. I hope that a lot of the information that you would have needed, you would have gotten tonight. And remember to continue to send in your questions. Even when the show is done and you're watching it back, you can still send in your questions. We will take your questions next week. So viewers, have a wonderful, wonderful rest of the week. The rainy seasons are here. Be careful on the road again. Too many accidents. And as I always say, stay healthy. Take care.